electrolyte drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
The program will start at exactly 4 p.m.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempracough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempracough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
Let us put ourselves in the presence of the Lord. Our Heavenly Father, we praise and adore your mighty name. O Lord, we acknowledge your presence in this gathering and we humbly ask for your guidance. Let this be an opportunity for us to learn, to excel, and to be the best that we can be for you and for other people. May this gathering inspire us to be a living example of your goodness and grace wherever we are and whatever we are facing. Every day, remind each and every one of us that everything we accomplish is for your greater glory. Amen.
Bayang magiliw, peres ng silanganan, alab ng puso, sa dibdib mo'y buhay. Lupang hinirang, tuwid ka ng magiting, sa manlulupig, di ka pasisihin. Sa dagat at bundok, sa simoy at sa langit mong bangha, may dilatang tula at awit sa paglayang minamahal. Ang kisat ng watawat mo'y tagumpay na nagniningning, ang bituin at araw na kailan pa may di magdidilim. Lupa ng araw ng at ipagsinta, buhay ay langit sa piling mo. Aming ligaya ng pagmay mga api, mamamatay ng dahil sa'yo. Hoy tanghal, mutiang UP Medicina, ika'y bukal ng laghaman, karunungan. Ang hatid mo'y pag-asa at kaunlaran, sa aking bayang nagdurusa at nagdaramdam. Hoy tanghal, kolehiyo, minamahal, sa isang ka ng buhay at kalusugan. Ang ngiti mo'y paglingkuran ng lipunan, malaya ka, makatao, makabayan. Hoy tanghal, kolehiyo, minamahal, sa isang ka ng buhay at kalusugan. Ang ngiti mo'y paglingkuran ng lipunan, malaya ka, makatao, makabayan.
Good afternoon to all of you. Magandang hapon po sa inyong lahat. I am Dr. Maria de Briones Palmes. I am an OBGYN sonologist practicing in Iloilo City. I am a proud member of the UPCM class of 1997 and one of the heads of the scientific committee for this postgraduate course and community service offering of our class. With me today is Dr. Ceciline Sanchez Acosta. She is a pediatric cardiologist practicing in the National Capital Region. Len is also a part of UPCM Class 1997 and will serve as our officer for today. She has some reminders for us this afternoon. Len?
Reminders. For those who cannot be accommodated by the Zoom webinar, viewers may access the live stream via UP Class 97 YouTube channel or via UP Manila live stream or via UP Med webinars. Attendees for the platforms other than Zoom must answer the attendance form provided in those platforms, while Zoom attendance is already automatically recorded. Your questions will be entertained at the end of 2 lectures or each session. Type in your questions in the Q&A tab as shown in the screen. If you want to prioritize a question, you may upvote the question by clicking the like button. At the end of the program, a link will be seen at the chat box for the evaluation and post-test. Click the link and answer carefully. The link will only be available after the last lecture and will be open for only 1 hour after the event. A system-generated e-certificate will be sent to your email after 1 to 2 weeks upon further verification. A second certificate will not be issued in case of errors.
Thank you, Lan, for those reminders. To start off the session this afternoon, let me introduce you to 2 of our classmates who will serve as moderators for today. Dr. Maria Susan B. Villaluz will moderate the first 2 sessions, and Dr. Melissa Pachon Dabao will moderate the last 2 sessions. Sansu?
Good afternoon. I am Dr. Maria Susan Villaluz. I am a proud member of the University of the Philippines College of Medicine class of 1997. And I am an obstetrician and gynecologist specializing in maternal fetal medicine and ultrasound in OBGYN. And I am currently practicing in Cebu. I will be your moderator for the first session. Our first speaker is a batchmate of mine. She is Dr. Brenda Bernadette Bautista Zamora. After graduation from the College of Medicine, she finished her residency training in obstetrics and gynecology at the University of the Philippines, Philippine General Hospital, followed by a fellowship in maternal fetal medicine at the Philippine Children's Medical Center. She's a fellow of POGS, as well as the Society of Maternal Fetal Medicine and the Society of Ultrasound in Obstetrics and Gynecology. Currently, she is an Assistant Professor 5 of the University of the East Ramon Magsaysay Memorial Medical Center. She is a medical specialist 2 at the East Avenue Medical Center.
For our objectives, first, we aim to recognize the global framework for action so that we can improve nutritional care and support of pregnant women. We shall increase the awareness of the impact of nutrition on pregnant women and the child within. And lastly, we shall discuss nutrition interventions according to global guidelines with emphasis on micronutrient supplementation during pregnancy. The outline of our lecture will be as follows. Let's start off with nutritional care of pregnant women. Why is nutritional care of pregnant women important? This is an interesting publication from the FIGO, or the International Federation of Gynecology and Obstetrics, published in year 2015. And this was their project, Think Nutrition First. The FIGO calls for increased awareness of the impact of women's nutrition on themselves and future generations. The FIGO supports action so that we can improve nutrition among adolescent girls and women of reproductive age. You see, good nutrition is fundamental for good health. With maternal nutrition, this affects not only the woman's health, but likewise that of future generations. You see, with poor nutrition among women in the reproductive age, this would increase the risk of adverse pregnancy outcomes, that is, both for the mother and the child. This is the central role of nutrition in determining health across life course and across generations. In all stages in a woman's life are connected by the effects of both good nutrition and poor nutrition. Poor nutrition at any stage has negative consequences that can disrupt the cycle and impact later life stages. Let's take a look at poor nutrition during adolescent health. That will render them with poor school performance, impaired reproductive health, and they're more prone to chronic illness. Reproductive age women with poor nutrition would have reduced work capacity and poor family care. We all know that women during pregnancy and breastfeeding, if with poor nutrition, will be at risk for both maternal and neonatal morbidity and mortality. And likewise, as to our outcome, the infants, the children, with poor nutrition, they will be rendered with stunting, poor cognitive development, and will be at increased risk for both acute and chronic diseases. Substantial evidence now shows that good maternal health and nutrition, both before and during pregnancy, can have a positive effect on the long term risk of non communicable diseases. And what are these non communicable diseases? That would be your cardiovascular or heart attack and stroke. You have cancer, chronic respiratory diseases like your chronic obstructive pulmonary disease and asthma, and also diabetes. The World Health Organization developed a global action plan for the prevention and control of these non communicable diseases. We created health promoting environments that which would encourage positive lifestyle factors like healthy diet and exercise. At the same time, we discourage negative factors. We campaign against tobacco and alcohol use. Here you will see the World Health Assembly Global Nutrition Targets for year 2025. For us obstetricians and gynecologists, we aim for a 50% reduction of anemia among women in the reproductive age, and likewise target for 30% reduction in low birth weight, and also increase the rate of exclusive breastfeeding in the first 6 months up to at least 50%. And for our pediatrics counterparts, we aim for a 40% reduction in the number of children under 5 who are stunted, and of course, no increase in childhood overweight. And lastly, reduce and maintain childhood wasting to less than 5% from 8% come year 2025. Interestingly, let's take a look at our local health situation. This is a local publication in year 2017 by the group of Goyena et al. On determinants of chronic energy deficiency and overweight obesity among non-pregnant mothers aged 19 and older. This was a cross-sectional analysis covering more than 10,900 participants. It was noted that overweight obesity prevalence was threefold higher as compared to your chronic energy deficiency. With chronic energy deficiency, this was significantly influenced by young age and single or live-in marital status. On the other hand, overweight obesity was associated with older age, higher educational attainment, higher wealth index, and young age at first pregnancy. Moreover, in year 2020, we also have another local publication from our chancellor, Dr. Carmencita Padilla and her group. This was on identifying challenges to the quality and preconception healthcare among women of reproductive age, and the chosen population was that of Lipa City, Batangas. This was a thematic analysis of data with focus group discussions covering more than 4,300 participants. They used a preconception checklist tool. Results show that indeed there are salient gaps in preconception healthcare, particularly with regards to micronutrient intake. Moreover, results show that there are major gaps in medical and educational services, particularly that of adolescents. Let's take a look at the table of results. The table above shows you the frequency of micronutrient intake according to age of study participants. We start off with the adolescent age and then presenting to you results from those women in the reproductive age. We see the low frequency of micronutrient among this population. Even if we take a look at the table below, wherein the patients were categorized according to their study sites, even if we look at those in the rural communities, there was still low frequency of micronutrient intake in this population. This graph shows you the prevalence of anemia among pregnant women. In the Philippines, from year 2005 to year 2016, we see a marked decrease of the prevalence from a reported 42% to about 30%. But just the same, According to the World Health Organization and the UNICEF, 30% would still be moderate public health significance. Let's take a look at our local health goals. Based on our Nutrition Council report in year 2020, the Philippines is one of the highest low birth weight and highest stunting prevalence in Southeast Asia. One-third of adult women aged 30 and above are overweight. There's inadequate delivery of micronutrient supplementation to the adolescents. And lastly, we still lack data on local dietary diversity. The Philippines has a Philippine Plan of Action for Nutrition that would cover the years 2017 to year 2022. This was aptly entitled Ambisyon 2040, or the Philippine Development Plan and Sustainable Development Goals. Like that of the World Health Organization, it also covers objectives to reduce wasting among children, stunting, reduce micronutrient deficiencies, and of course, improve the situation of overweight and obesity. We have local interventions. We start off with several policies like that of the Expanded Breastfeeding Promotion Act, Food Fortification Law, Salt Iodization Law, and the first 1,000 Days Law. We have plans, strategies, and several programs at that. Let's now tackle impact of nutrition on pregnant women and the child within. Poor nutrition would render a woman at high risk for complications during pregnancy. Examples would be gestational hypertension, diabetes, preterm delivery, and even fetal growth restriction. Long term, we have concerns on perinatal survival, of course, the future health of the offspring, and as mentioned earlier, the risks for your non-communicable diseases. This is an interesting graphic representation of the life course model of chronic disease. What you see in the on the x-axis would be time across generations that covers preconception and pregnancy, infancy and childhood, adolescence and adulthood. On the y-axis, you see the increased risk of chronic disease risk that is passed on from one generation to the next. Our current situation, we have a high risk trajectory of passing on chronic disease risk from one generation to the next. But interestingly, newer studies have shown that there is a particular intervention before birth, meaning during the period of preconception and pregnancy, that can decrease this risk trajectory. And it has been identified as modification of nutrition, therefore decreasing this risk trajectory, decreasing the risk of passing on chronic disease risk from one generation to the next. In this figure, you see the relationship of preconception and in utero environment to the developmental plasticity of that of the fetus within and the immediate outcome. With maternal diet and body composition, this would affect potential oocyte and embryo responses, be it in epigenetic modifications, altered intracellular signaling, metabolic stress, apoptosis, or altered cell differentiation and proliferation. This would subsequently affect the fetus within, maybe through genetic expression, altered fetal growth rate, altered setting of the neuroendocrine axis, and abnormal birth weight. And for the outcome, potential long-term consequences will involve stunting, impaired neurodevelopment, obesity, cardiovascular, and metabolic diseases. Now, this does not stop here. This would now affect the following or subsequent generations. Let's talk about malnutrition. Undernutrition would mean inadequate intake of macronutrients like your calories and protein. Micronutrient malnutrition would be inadequate intake or increased losses of specific or multiple vitamins and minerals because of an unbalanced diet. On the other hand, you also have overnutrition under malnutrition. With overnutrition, this can occur even in the context of excess energy intake if the diet is nutrient poor. Undernutrition would likely be due to a deficiency in a number of micronutrients, and that would include your iron and folate, which would render our reproductive women with poor reproductive performance. As to outcomes, you have neonatal outcomes and long-term effects that would involve presence of congenital abnormalities, low birth weight, stunting in childhood, short adult height, and even lower educational attainment and reduced economic productivity thereafter. Overnutrition would cover regular consumption of excess energy, leading to overweight and obesity. Health risks, you have hypertensive disorders during pregnancy known as your preeclampsia, gestational diabetes mellitus, for which your outcomes would have high blood insulin, macrosomia, and neonatal hypoglycemia. Likewise, there's increased risk for congenital abnormalities, stillbirth, childhood obesity, and later on, risks for non-communicable diseases. How about micronutrient malnutrition? This would be vitamin and mineral deficiencies that may be secondary to several factors. Maybe one, due to inadequate intake, or two, because of low bioavailability of the nutrients, or lastly, maybe because of increased nutrient requirements. Example, during pregnancy. When there is deficiency in the mother, this would translate to deficiency in the fetus and the newborn. So what are the nutrients of concern? We have iron, folate, and vitamin B12 involved in blood health, calcium, vitamins A and D, and zinc, iodine, and selenium. Let's now tackle the guidelines on micronutrient supplementation. Well, we always think nutrition first. This is the composition of a healthy diet for adults as defined by the World Health Organization, which focuses on presence of fruits, vegetables and legumes, and nuts and whole grains as well. Interestingly, this one has listed down the minimum dietary diversity index for women according to the food groups. It is recommended by the World Health Organization for intake of more than or equal to 15 grams per day of each of 5 or more of the following food groups. Here you have your starchy staple foods, beans and peas, nuts and seeds, dairy, meat, poultry and fish, eggs, vitamin A rich dark green leafy vegetables, and vitamin A rich vegetables and fruits. As to global guidelines, there are several approaches to reduce micronutrient deficiencies. Interventions to control micronutrient deficiencies among adolescent girls and likewise women of reproductive age can be broadly divided into three. First, you have dietary modification, and then food fortification, and lastly, supplementation. Let's start off with dietary modification. This would just mean improving the variety in the diet, improving intake, absorption, and utilization of vitamins and minerals. Example, we encourage taking in of food that is rich in bioavailable iron, like your meats and vegetables. Also, we take note of the food processing techniques. We use fermentation so that we can reduce phytate content, which we all know is an iron absorption inhibitor. How about for vegans? Well, we can encourage that they choose to eat animal products, or by now they can tailor their diets to use a nutritional yeast that is now fortified with vitamin B12. How about food fortification? It's already mandated that to fortify at least one industry milled cereal grain, mainly with iron and folic acid. With fortification of both iron and folic acid, it has proved to be an effective and likewise safe strategy to reduce anemia and prevent the occurrence of your neural tube defects. There is also food fortification for condiments. All food grade salt is now fortified with iodine, and this is safe and effective. It is a strategy for the prevention and control of iodine deficiency disorders. Likewise, other condiments like soy, fish sauces, curry powder, and bouillon cubes can now be useful alternatives likewise for iron fortification. Supplementation. Supplementation is the direct provision of vitamins and minerals in the form of liquid, pill, tablet, or dispersible formulations. We focus on current supplementation efforts of iron, folic acid, iodine, calcium, and likewise multiple micronutrient formulations. During our prenatal consults, we involve other professionals like community health workers, nutritionists, family doctors, the OBGYNs, and midwives. During the assessment, we consider the risk for specific nutritional problems in all trimesters of pregnancies. Discussion points should not only cover dietary counseling, but as well as supplementation. Example, concerns on folic acid, iron, and other requirements like iodine, vitamin B12, and vitamin D. This tabulation is from the FIGO, which is also based on the Institute of Medicine recommended dietary allowance and adequate intake guidelines. Let's start off with folate. The recommendation for folate intake would be 400 micrograms during the pre-pregnancy period and 400 to 600 micrograms from pregnancy up to lactation. How about vitamin B12? That's 2.4 micrograms in pre-pregnancy period and 2.6 to 2.8 micrograms during pregnancy up to time of lactation. How about vitamin D? That would be no less than 600 international units of vitamin D daily. For calcium, that's 1,000 milligrams to 1,300 milligrams of elemental of calcium per day. And for iron, this was their initial recommendations. However, we have to tailor fit this for our population. In the background, with increased prevalence of anemia in reproductive age women, the recommendation is 60 milligrams of elemental iron during the pre-pregnancy period, and likewise 60 milligrams of elemental iron during the course of pregnancy up to time of lactation. As to zinc, that's 8 to 9 milligrams in the pre-pregnancy period and 11 to 12 milligrams during pregnancy and lactation. Now, when asked, is supplementation with micronutrients still necessary during pregnancy? Well, here I present to you a 2021 review, which was just recently published, and that shows you or summarizes to you the results of multiple randomized controlled trials. I have tabulated them accordingly. Micronutrients play critical roles, be it in embryogenesis, fetal growth, and maternal health, as energy, protein, vitamin, and mineral needs can increase during pregnancy. Increased needs can be met by increasing the intake of dietary micronutrients. Let's take a look at vitamin A. Vitamin A is important in the regulation of immune function. With vitamin A deficiency, this has been associated with premature births, growth restriction, low birth weights, and increased maternal mortality. Recent RCTs say also that vitamin A deficiency is associated with placental abruption and preeclampsia, most likely secondary to the theory of oxidative stress. How about vitamin C? Vitamin C contributes to reducing oxidative stress and improves the course of preeclampsia, and together with vitamins A and E would make up the group of antioxidants. With vitamin C deficiency, it was identified to be associated with increased risk of infections, premature rupture of membranes, and preeclampsia. For vitamin E, there is decrease in serum levels among older women and later in breast milk. As to deficiency of vitamin E, this has been associated with increased risk for preeclampsia, abruptio placenta, and often would have preterm outcomes with low birth weights, who are in the long run would be at high risk for hemolytic anemia. Vitamin E deficiency is also associated with bronchopulmonary dysplasia, intraventricular hemorrhage, periventricular leukomalacia, retinopathy of prematurity, and also necrotizing enterocolitis. Vitamin D. Vitamin D is essential for the maintenance of bone mineralization and calcium homeostasis. With deficiency in vitamin D, it will alter calcium metabolism. It would increase the risk of preeclampsia, gestational diabetes, cesarean section, bacterial vaginosis, and increased risk for preterm delivery. With vitamin B6, this is essential for the development of the nervous and cognitive systems. With vitamin B6 deficiency, it has been identified that this can account for some types of anemia in pregnancy that would be unresponsive to your iron supplementation. How about vitamin B1 and B2? They're both essential for fetal growth, vital for muscle, nerve, and bone development. For deficiency of vitamin B1 and B2, you will have your beriberi and your Wernicke's encephalopathy, and vitamin B2 deficiency that would manifest as skin disorders. Folic acid and vitamin B12. Folic acid reduces the incidence of neural tube defects, and recent studies have also shown that it can decrease the risk of childhood acute lymphoblastic leukemia. For vitamin B12, this is essential for brain and nervous system and also for formation of blood proteins. With deficiency in both folic acid and vitamin B12, they were able to note that this can increase the homocysteine levels in the blood, therefore rendering it neurotoxic and vasculotoxic, most likely involved in its teratogenic effects that cause neural tube defects. Calcium. It is essential for bone maintenance, nerve transmission, neuromuscular excitability, smooth muscle contraction, blood clotting, and enzyme activation. With calcium deficiency, this has been linked to the development of preeclampsia, microangiopathy, and having premature outcomes. For iodine, we just need to emphasize that it has a high impact on child neurological development and pregnancy outcomes. Iodine deficiency is responsible for what we have your endemic goiter, recurrent pregnancy losses, growth restriction, mental retardation, and cretinism. As most serious consequences for iodine deficiency, you have alterations in brain and neurological development of the fetus, which are irreversible at birth. Iron. It is an essential trace element that is part of hemoglobin. With iron deficiency, this is associated with anemia, growth restriction, preterm birth, and low birth weight. For zinc, this is involved in vital functions for cells, such as mitosis, DNA synthesis, and genetic expression and activation. Zinc deficiency is associated with preeclampsia, postpartum hemorrhage, and spontaneous miscarriages. For moderate deficit, you can have risks of premature rupture of membranes, preterm delivery, and low birth weight. Should you have severe zinc deficiency, this has been reported to be associated with congenital malformations that would range from palatal, cardiac, urologic, skeletal, and even brain defects. So in their study, their conclusion says that there is indeed evidence that micronutrient deficiencies negatively affect maternal health and the outcome of pregnancy. But for now, it is impossible to predict the possible effect of a multivitamin and mineral supplement that meets all the needs of a pregnant woman. Let's take a look at the WHO recommendations as published and updated in year 2020 on antenatal nutrition, and these are updates on multiple micronutrient supplements. So the possibility of giving one supplement that contains all the micronutrients necessary for pregnancy appears to be desirable. But note that micronutrient intake and deficiencies, they vary across regions, countries, and for specific populations. Several micronutrient formulations containing both your iron and folic acid has been studied in several randomized controlled trials, mostly in low and middle income countries. So here as tabulated on your right, you see the UNIMAP. This is the United Nations International Multiple Micronutrient Antenatal Preparation Formulation, for which it contains 15 micronutrients with 10 vitamins and 5 minerals. In this updated WHO recommendation, the recommendation is based on evidence derived from trials that used multiple micronutrient supplementation that contain 13 to 15 micronutrients that would include both your iron and your folic acid use prescribed for specific populations. It just emphasizes that pregnant women should be supported and encouraged to receive adequate nutrition, which is best achieved through consumption of healthy, balanced diet. Specifically, the recommendations would cover nutrition education and increasing daily energy and protein intake, a balanced energy and protein dietary supplementation, adjustments of your iron and folic acid supplementation based on prevalence of anemia, and in populations with low dietary calcium intake, the recommendation is 1.5 to 2 grams of elemental calcium per day. Let's take a look at the local guidelines. This one is from the Philippine Obstetrical and Gynecological Society in November of 2018. This is our CPG guidelines on maternal nutrition and supplementation. Let us just highlight the use and the recommendations for iron and folic acid. Daily oral iron and folic acid supplementation is recommended to be part of our prenatal care, as this will lower the risk of maternal anemia, puerperal sepsis, low birth weight, and preterm birth. Let's say for women who cannot tolerate daily oral iron intake, maybe due to side effects, or maybe the population prevalence of anemia is less than 20%, then intermittent oral iron supplement at 120 milligrams of elemental iron with 2.8 milligrams of folic acid given once weekly is recommended. Now, in settings where anemia, let's say in pregnant women, is a severe public health concern, prevalence rate of about 40%, then the recommendation is 60 milligrams per day of elemental iron with 400 micrograms of folic acid. Now, if a woman is diagnosed to have anemia during pregnancy, the recommendation is to give treatment at 120 milligrams elemental iron per day until her hemoglobin rises back to normal. And iron supplementation is doubled for special situation, doubled at a rate of 120 milligrams elemental iron daily for situations wherein the woman is large in size, is pregnant with multiples, is beginning supplementation late in pregnancy, meaning not able to cover 3 months daily intake of iron, and has been taking their iron irregularly. The Food and Agriculture Organization of the UN, the UNICEF, the World Food Program, and the World Health Organization issued this joint statement on nutrition in the context of the COVID-19 pandemic, specifically for Asia and the Pacific in April of year 2020. It says maternal nutrition health services should continue to provide essential nutrition services for both pregnant and breastfeeding mothers. Micronutrient supplementation programs to prevent and control micronutrient deficiencies should be continued during routine services for pregnant women and likewise among young children. For pregnant and breastfeeding women, we ensure that nutrition services with provision of iron and folic acid and also your multiple micronutrient supplements are still carried out to include nutrition counseling and also breastfeeding advice. Support for the treatment and care of patients with clinical signs and symptoms of micronutrient deficiencies should continue whenever possible, as these are critical interventions. Therefore, we include iron for our anemic mothers. So, supplementing the child within, in summary, we always think nutrition first. Proper nutrition of women should be considered as a goal to prevent nutritional imbalances that would interfere with pregnancy outcomes. Moreover, we've seen that there is evidence of the benefits of micronutrient supplementation in perinatal results, but indiscriminate use is discouraged due to the fact that side effects of excessive doses are not yet known. And lastly, it is important to promote supplementation through health education and that we launch a health campaign aimed for women of reproductive age. With that, I'd like to wish you all a good day. Thank you.
Thank you very much, Brenda, for a very detailed discussion. On micronutrient supplementation of the fetus. Our second speaker is Dr. Edward Vincent Faustino. Vince graduated magna cum laude from the University of the Philippines College of Medicine, class of 1997. He is an associate professor of pediatric critical care at the Yale School of Medicine. He is also a visiting professor in pediatrics at the University of the Philippines, Philippine General Hospital. He is a scientific committee member of the Pediatric Lung Injury and Sepsis Investigators. He is a co-chair of the International Society on Thrombosis and Hemostasis, Neonatal and Pediatric Subcommittee, as well as a co-chair of the Pediatric Protocol Review Committee, Yale School of Medicine. Vince also sits in the editorial board of the Journal of Pediatrics. His lecture is entitled Infection to Sepsis Spectrum, a Continuum from Maternal to Neonatal Infection. So I turn over the virtual floor to Dr. Faustino.
I'd like to thank my classmates for inviting me to give this talk on infection to sepsis spectrum, continuing from maternal to neonatal infection. The first bullet is my standard disclosure. However, probably more important is I'm a pediatric intensivist and I'm not a neonatologist and definitely not an obstetrician. So for purposes of this talk, I'll be focusing on the neonate, but obviously also considering the mother in the evolution of infection in neonates. So just an overview, I'm going to discuss three broad topics. First is congenital infections. Second is neonatal sepsis. And I'm going to end with perinatal COVID-19. So neonatal infection is a significant problem globally. This is a breakdown of the cause of death in the neonatal period around the world. And if you consider diarrhea, tetanus, pneumonia, and sepsis together, then we're looking at least 25% of the mortality in the neonatal period as secondary to infection. But we also know that a lot of these preterms, which comprise 36% in this figure, die of infection. So I wouldn't be surprised if the proportion of neonates dying because of infection globally is more than the 25% shown here. There are three modes of transmission of infection from mother to infant. First is congenital infection. Second is perinatal infection, and which happens as the baby goes through the birth canal. And then third is postnatal infection. I'm going to touch base these three different modes of transmission of infection during the lecture. So let's start first with the congenital infection. We all know about TORCH, right? But as time grows, the O in TORCH actually gets getting bigger and bigger. We're familiar with toxoplasmosis, rubella, syphilis, CMV, but now we also have to deal with Zika virus and then HIV infections. As you can see from this table, that there are certain times during the pregnancy where the neonates, the fetus is more susceptible to the infection. So, for example, rubella occurs. Congenital rubella infection usually occurs during early pregnancy, while chickenpox occurs more later, like during late pregnancy, intrapartum, and postnatal. Cytomegalovirus, on the other hand, occurs all throughout the pregnancy and even during the intrapartum and postnatal period. The AAP Red Book and the CDC has different, different but related guidelines in terms of diagnosing TORCH infection in neonates. So specifically, you have antibody testing for toxoplasma to diagnose toxoplasma, and similarly for rubella. For cytomegalovirus, for example, the AAP Red Book recommends tissue or blood culture or PCR. However, clinically, we tend to do a lot of testing using testing the urine to diagnose, or at least screening for cytomegalovirus in the urine in patients who are suspected of having a congenital infection. I'm not going to go through each one of the TORCH infections, or we're going to use up the 30 minutes allotted to me, but I just want to focus on some of the congenital infections, which I think are more pertinent. So we can get away without touching base with CMV infection. During my time in the college, I don't think we spent really a lot of time talking about CMV infection, but it's actually the most common congenitally acquired infection. There are two modes of transmission. One is primary, and this occurs in women or mothers without any pre-existing, without prior infection and no pre-existing immunity. The rate of transmission is pretty high. So 1 of 3 mothers with a primary CMV infection would most likely transmit the infection to the child. However, it only comprises about 1/4 of all the CMV infections at least in the US. The non-primary or reactivation of latent CMV has a lower rate of transmission, like 0.1 to 1.7%. However, 3/4 of the congenital CMV infection in the US can be attributed to non-primary. Because of the burden of illness attributed to CMV infection, there's a lot of studies ongoing right now in the US in terms of development of vaccines against CMV, and none of them has been approved for clinical practice, and there are some issues in terms of gaining enough immunity against CMV. But at least that's ongoing, and hopefully in the near future we'll have some of these vaccines available in the market. So how do you manage patients with units with CMV? So in terms of diagnosis, you have your laboratory tests. It's important to assess for hearing. So we usually do a brainstem evoked response to detect sensory neural hearing loss. We look at the eyes. So we have a ophthalmology exam for chorioretinitis. And then we have a neuro imaging. We usually start with ultrasound, but eventually we end up doing MRIs just to have a better idea of the extent of neurologic injury. The primary drug of choice is intravenous ganciclovir or oral valganciclovir. And then because this is really a multisystemic disease, it's important to take care of the whole infant and whole neonate and not just a particular organ systems. However, the most distressing complications of CMV infection, neonatal CMV infection, are those involving the cerebral nervous system, such as seizures. And then you also have some hematologic abnormalities, but it's usually the neurologic involvement that involves a lot of care and costs a lot of resources for these infants. What about perinatal HIV? Again, I'm not going to go into details of HIV infection, but I just want to discuss with you how perinatal HIV is currently managed. So the mothers are, and the neos are referred to in terms of two categories: low risk of perinatal HIV transmission, and in the next slide, I'm going to show you about high risk perinatal HIV transmission. So it's easier to define low risk. So these are infants who are born to mothers who received antiretroviral therapy during pregnancy and has sustained viral suppression at the time of delivery. So these are basically controlled HIV infection in the mother. So when do we test these babies? So we test them at 14 to 21 days, and then repeated at 1 to 2 months, and then 4 to 6 months, 6 months of birth. They're usually started with a single drug, zidovudine, and then they're given 4 weeks of this drug. Management obviously differs in someone who's at high risk of perinatal HIV transmission. And basically, if you don't qualify under the low risk of transmission, most likely you're going to be under the high risk of perinatal HIV transmission. So we test them more frequently, so starting at birth, and then we also test them 2 to 6 weeks after the antiretroviral prophylaxis is discontinued. We start them on a 3-drug regimen: zidovudine, lamivudine, plus either nevirapine or raltegravir. And usually for these patients, we recommend pediatric HIV expert consultation in order to guide therapy. Years before COVID-19, Zika virus was in the news. I'm not sure how many, what the burden of disease of Zika virus is in the Philippines, but I want to highlight this congenital infection for one particular reason, because humans may actually be a reservoir for the virus. So Zika virus can be transmitted to the baby during perinatally. So that's what you call perinatal Zika virus infection. It can be congenital, right? So mom has a Zika virus, gets passed on through the placenta and down to the baby. But the other sort of distressing thing is the placenta. The virus can actually stay in placental cells, such that the mother becomes a reservoir, and congenital Zika virus infection may occur in subsequent children. This is not definite definitively proven as of present time, but at least that's something to consider. And obviously, this is important in terms of perinatal infections. So moving on to neonatal sepsis. So as I mentioned earlier, I'm not a neonatologist, but I still take care of patients with neonatal sepsis, even in the pediatric ICU. So the unfortunate thing is there's no unified criteria for neonatal sepsis. In the adult world, in the mid 20s, so 2016, the adults redefined sepsis. So currently the thinking is it's a life-threatening organ dysfunction caused by a dysregulated host response to infection. We have moved away the concept of SIRS or systemic inflammatory response syndrome because prior to this definition, sepsis was referred to as a SIRS that is probably due to infection. The good thing with this definition is that short-term outcomes are validated in large cohorts of adults with sepsis. So it's not just a group of people sitting around the table and trying to figure out how to define sepsis. What they actually did was to look at the large cohorts of adults with sepsis and see whether if you're diagnosed with sepsis or how you diagnose define sepsis, whether that's associated with mortality. The unfortunate thing is children were excluded in this sepsis 3 definition, and obviously if children are excluded, then that also goes through for neonates. To operationalize this sepsis 3 definition, the group suggested using the sequential organ failure assessment score, or the SOFA score. So this is a scoring system that looks into the respiratory system, coagulation, liver, cardiovascular, CNS, and renal. It's really hard to remember like all this scoring systems. So to make it easier to use in the clinics, they came up with a quick SOFA score, which is just based on these 3 parameters. So respiration, or rate of more than 22 per minute, cardiovascular, systolic blood pressure of less than 100 millimeters mercury, and then altered mentation. So in the presence of 2 of these 3 parameters, then the patient is assumed to have sepsis and then manage the sepsis. In the pediatric world, for older children, there is the pediatric SOFA score, which is basically patterned after the adult SOFA score. And this has been shown to have some validity, particularly in terms of early mortality or in-hospital mortality. There's also the neonatal SOFA score, but this is for very low birth weight infants with late onset sepsis. So because there's no unified criteria for neonatal sepsis, in the literature, there's probably at least 5 that I've seen that's been used both for clinical practice and for clinical trials. Probably more pertinent for your use is the IMCI and the WHO criteria, which I'm pretty sure you're very much aware of. So this is the IMCI or the WHO's criteria for severe infection in the less than 2-month age period. So it follows the same concept as the sepsis 3 definition. So you have neurologic, respiratory, cardiac, GI, dermatologic, musculoskeletal are not part of sepsis 3 definition, but the IMC and then World Health Organization actually consider them as part of their criteria. So what are the bacterial causes of neonatal sepsis? So for developing countries, gram-negative organisms are more common. So you have Klebsiella, you have E. coli, Pseudomonas, and Salmonella. Gram-positive organisms are less common. So you have Staph aureus, Strep pneumo, and then Strep pyogenes. I was actually surprised when I was reading this article because, we're always, or at least I was taught during med school, that group B strep is a common cause of at least early neonatal sepsis, but this article did not even include group B strep. So I guess that's a bias in textbooks, right? Because they're really geared towards developed countries. So our typical notion of gram-negative organisms, or more specifically E. coli, and then GBS for gram-positive organisms. So that's really the epidemiology of neonatal sepsis in developed countries. And understanding these differences are obviously important, because your drug of choice, at least for empiric treatment, will depend on what the prevalent organisms are. So, because this data is usually is from the United States, uh, they compared the rates of early onset sepsis during the 2006 to 2009 period versus 2015 to 2017. Sort of in between these two epochs, where the use of intrapartum antibiotic prophylaxis, which specifically targets group B strep. So if we look at these two epochs, there's really no statistically significant increase in the rates of early onset sepsis. It's 1 per 1,000 live births in epoch 1, and then 1.16 in epoch 2. However, if we stratify this rate into GBS and E. coli, we can see that for GBS, the rate is the same or slightly decreased, at 0.42 versus 0.36. But for E. coli, it's definitely going up, so from 0.27 to 0.4. So this indicates two things. So first is prophylaxis likely works. But the other thing is it's only specific to GBS. So we need to figure out how to provide prophylaxis for E. coli. The fact that the rate of GBS is the same and has not gone down also suggests that we still have some work to figure out how to minimize or eliminate the risk of early onset infection, early onset sepsis from GBS. I'm not going to go through the management of neonatal sepsis. I think I remember, like, even as a medical student, this has been drilled to us in our pediatric lectures. So we still follow the IMCI management, and really this is you need to classify the severity of illness based on the presenting signs and symptoms, and then identify treatment based on this protocol. I don't have the exact data, but the way these patients are managed globally has led to a significant decrease in neonatal sepsis around the world. What I want to present to you guys is, again, like, rather than rehashing what IMCI suggesting or recommending to do, is sort of like what's out there. So there's a lot of work on biomarkers of neonatal sepsis. Typically, at least clinically, we usually look at leukocyte counts. Maybe sometimes we look at ANC and probably platelet count. However, the studies have already shown some improvement in the diagnosis of sepsis with the use of C-reactive protein or calcitonin. But outside of this, there's like a huge number of markers that's being investigated out here. So they range from acute-phase reactants to cytokines and chemokines, and then now there's also molecular diagnostics. And this is really based on PCR. But as I mentioned earlier, most of these are still in the research phase and has not crept into a clinical practice. But I wouldn't be surprised if the next number of years is going to be clinically available, and it's going to completely change the way we manage our patients. So one of the problem with management of early onset sepsis is trying to figure out who needs treatment or not, right? Empirically, at least. So rather than discussing the risk factors, this is sort of like the new thing. Like there's a lot of groups that are coming up with calculators. So they're based on risk prediction models. It gives you some value, and then based on that value, it suggests like what you should do clinically. And I found this one from Kaiser Permanente group, and you enter the baseline incidence of early onset sepsis, the patient's gestational age, and the other risk factors for sepsis. You click calculate, and then it gives you what your risk is at birth. And then based on this, based on the clinical exam of the neonate, it suggests like what you should be doing in terms of clinical recommendation and in terms of management of vital signs, patients' vital signs. This has become pretty popular because we try to limit giving antibiotics to these patients, and for all intents and purposes, for all patients who probably would not benefit from antibiotics. So this has been validated in developed countries. It would be nice to see whether similar calculator can be used in developing countries, and again, just to minimize excessive antibiotic use. So the prevention of neonatal infection starts from the mother, right? Even before the mother becomes pregnant, you need to make sure that they have improved maternal nutrition, because this is directly related to immunity. You want to screen and manage maternal infections appropriately, and obviously maternal vaccinations. As you can see, a lot of the torch infection may actually be prevented from maternal vaccinations. During the intrapartum period, obviously hygiene is very important. So optimal hand washing, clean birth practices, and steroid cord cutting. I mentioned intrapartum antibiotic prophylaxis for mothers with known GBS colonization, and then prophylactic antibiotics for those with history of premature rupture of membranes. And then it doesn't stop there. So postnatally, there's immediate post-delivery drying, thermal protection, and kangaroo care, dry cord care for newborns. And I want to emphasize optimal feeding practices, and that means early and prolonged breastfeeding. I think I'll be preaching to the choir if I tell you how important breastfeeding is, especially for developing countries with limited resources. And again, the use of prophylactic antibiotics for neonates only for those with risk factors. So it should not be an indiscriminate use of antibiotics. So I don't think a talk nowadays will be complete without a discussion of COVID-19. So at least in the neonatal period, there are three major presentations of COVID-19. First is early neonatal COVID, which the good thing is they tend to be uncommon. So it's only 1.6% of infants born to positive mothers. Most of these kids are asymptomatic and just detected by routine testing. At present time, we think that vertical perinatal transmission of COVID-19 is probably uncommon. These kids would present similarly as any other patient with sepsis, with temperature instability, inability to feed, some nasal congestion, and irregular breathing. Then you have the late onset neonatal COVID, which is usually they get readmitted 5 to 35 days after birth, and this tends to be more like how we would describe respiratory COVID. Right? So you have respiratory distress, you have apnea, and then because of that they have a feeding intolerance. So usually, so these are postnatal transmission, and it's just like any other patients, like it's transmission from other members of the household. This figure shows MISC in neonates. Honestly, I don't think I've seen someone like in the neonatal period present with MISC. But obviously, it can happen. So what about in women? So the unfortunate thing is, as much as COVID-19 is uncommon and usually benign in neonates, it's not that good for women. So just focusing on this table, so you have the risk of IC admission, invasive ventilation, ECMO mortality is much higher. It ranges from around 2 to 3 for pregnant women relative to those who are non-pregnant. And the risk is higher for women at 35 to 44 years old, Hispanic and African American, and Asian and Native Hawaiian Pacific Islander. So these patients usually present with respiratory COVID. The problem is because there are physiologic changes due to pregnancy, they are at high risk for respiratory compromise. So how do we prevent COVID-19 during pregnancy? It's the same thing as how you would prevent COVID-19 in other patient groups. So you have hand washing, you avoid crowded places and masking, and then physical distancing. During the time that this review was published, they weren't sure. We've always thought that vaccination against COVID-19 would be more beneficial, and safe for pregnant women. But again, during this time, the data wasn't out there. This year, that data has come out. So it's a systematic analysis of basically all available studies, on COVID-19 vaccination during pregnancy. And what they've shown is the vaccine is effective with an effectiveness of 90%, which is actually very good. Slightly less than I think like 95% reported initially for Pfizer, but definitely this is very good. Oh, I just want to mention that these are all mRNA vaccines. The vaccine is safe because they don't lead to adverse events in the mother. So none of these are statistically significant. And in fact, it may actually be protective for the neonates. So there's a statistically significant reduction in the risk of stillbirth and asphyxia. All the other concerns for adverse outcome in the neonates are really unfounded. So I just want to emphasize, the effectiveness and safety of COVID-19 vaccination during pregnancy. So in summary, infection and sepsis continue to be significant causes of neonatal mortality and morbidity worldwide. Strategies to prevent these infections begin with the optimal care of the mother. And these strategies form the foundation for preventing the spread of future disease-causing microorganisms in neonates. Again, thank you very much for the opportunity to present this talk to you. I'll be more than happy to answer questions.
Thank you very much, Dr. Faustino, for a very in-depth and elaborate lecture on the spectrum of maternal to neonatal infections. He's coming all the way from Yale University in the USA. Can we have Brenda and Vince? Hi, Brenda. Hi, Vince.
Oh, yeah.
Okay. Let's now proceed to our question and answer portion. My first question would be to Brenda. In the chat, in the Q&A box, there was a question about physiologic anemia in pregnancy. So I would just like to ask if we are considering a woman who is not anemic, how do we supplement with iron during pregnancy?
All right. Thanks, Sansu. With regards to the question on physiologic anemia, technically it will just be defining anemia, which is sort of in a hemodilution state, meaning um the serum volume increases compared to the RBC mass, which increases slower, but it increases throughout the rest of pregnancy up to about 32 or 34 weeks age of gestation. But with regards to supplementing women, let's say they are not anemic, first, I think the recommendation to reiterate is that we screen all our pregnant patients during their first booking. Hopefully that we see them during the first trimester. And again, sometime about 28 weeks age of gestation again. And then the second recommendation is, should these patients not be anemic, we still continue to supplement them with your low dose iron supplementation. And that, according to the FIGO and the WHO, that would be your 27 milligrams elemental iron per day. For our local practice, it will be available at 30 milligrams elemental iron daily.
Thank you very much, Brenda. There's another question here for Vince in the Q&A. Do you require the mother with HIV to be tested first with viral load before suggesting pregnancy?
So it's probably a question for the obstetrician. I'm a pediatrician, but in general, but at least in the US, HIV screening is part of the prenatal workup. So I mean, they get like especially the high risk patients, they get tested certain time points. But I guess it's a good idea to test them right before getting pregnant.
We usually screen all our pregnant patients for HIV in the first prenatal visit. But how about Brenda? Do we check for the viral load?
I'm not so sure if we do, but I think the others would also suggest that if you are to be preparing for pregnancy, it's better to check so that we just know what we're preparing for. But hardly do we see them in the preconception period. We usually see them already pregnant at that time.
Yeah.
But I think what's more important is to campaign for the HIV screening, that it shouldn't be a taboo subject. It should be pretty much routine. Should be.
Thanks, Brenda. There's another question here. Is there a vertical transmission of antibodies against COVID among infants born to COVID positive mothers and vaccinated mothers? Who would like to answer the question? There's no specific person being asked here. Brenda?
Well, I'm not an IDS specialist, but I think we want to document that too. But in the local practice, I'm not sure if we're doing it already. But what we're trying to explain also is when you get the vaccine, it's pretty much transferred to the baby. That's why we encourage the vaccination during the pregnancy as well. And technically that baby would have the antibodies also when they're born. So, but as to the testing or a study about it, I think they're about to do it, but I'm not sure if they started it already because we always wanted to document the vertical transmission to the outcome.
I think antibodies are transferred. I think there
Yeah,
are small studies to that effect. Vertical transmission of infection is less likely. I think most of the perinatal infection are still horizontal.
Yeah.
So antibodies cross, infection probably doesn't.
And I think also maybe to add to that, Vince, Sansu, the adverse outcomes in COVID among COVID mothers would not usually be attributed to the COVID infection of the outcome, but more of the complications brought about by the COVID in a pre-morbid mother. Yeah.
Okay. This question is for Vince, I think. If IV Hancyclovir doesn't work for CMV, is there any alternative drug available?
So we don't use Hancyclovir in the US. We actually use Valganciclovir. So it's the first time I've heard about Hancyclovir. We do Valganciclovir. So it may just be it's the way drugs are marketed across the world.
Okay. There's one question here for Vince also. What's the difference between now SOFA and MODS?
What's that? Where's the
This is the question, a phone-in question.
phone-in question?
SOFA. What is the difference between SOFA and MODS? I think your
okay.
scoring system.
Yeah, the SOFA score is the scoring system for MODS. SOFA is sequential organ failure assessment score. And then MODS is multi-organ dysfunction syndrome. So MODS is sort of the diagnosis. That's a syndrome, and then the way you pick it up or diagnose is based on the SOFA score, or at least one of the ways to do it is through the SOFA score.
Okay. Thank you very much, Brenda. Thank you very much, Vince. At this point in time, I'd like to award our certificate of appreciation. The certificate reads the University of the Philippines, Manila, postgraduate, wait lang. Medyo malabo ang slide, sorry. Okay, thank you. Postgraduate Institute of Medicine, University of the Philippines College of Medicine, class of 1997, presents this certificate of appreciation to Brenda Bernadette Bautista Zamora for sharing her expertise as speaker on the topic supplementing the child within during the UPCM class 1997 postgraduate course, UPCM Health 97, Unraveling the Perplexities of Child and Maternal Health, given this 10th day of June 2022 via the virtual platform. It's signed by Dr. Ces Alinea, Chair, the CME Committee, Dr. Teresa Luisa Cruz, the Director of the UP Postgraduate Institute of Medicine, our class president, Juan Antonio Maximiano Escano, Deb Briones Palmes, the chair of the postgraduate course, and Efren Balanag, chair also of the postgraduate course. The same certificate is given to Dr. Edward Vincent Faustino for his lecture on infection to sepsis spectrum, a continuum from maternal to neonatal infection. So this is also signed by the same people. Thank you very much again to Vince and to Brenda for giving very interesting lectures. I turn you over now to our moderator for the second session, Dr. Melissa Pashon Dabao.
There. Hi, good afternoon. I'm Dr. Melissa Pashon Dabao, a dermatologist, a proud member of the UP College of Medicine, class 1997, and I will be the moderator for this session. Our first speaker is another dermatologist, Dr. Maria Cristina Filomena Arbata. She, of course, graduated at the UP College of Medicine, class of 1997, and she took up her residency in the same institution. She is currently a fellow of the Philippine Dermatological Society, as well as a clinical associate professor of the Department of Dermatology at UPPGH. She's a senior lecturer at the Department of Medical Microbiology at UP College of Public Health. She took her Master's of Science in Medical Mycology at the University of Manchester at the United Kingdom, and a Master of Science in Epidemiology in Public Health at UP Manila. So her lecture is entitled Eczema and Other Dermatoses of the Mother and Child. So without further ado, let's go, Tina.
Good day. For today, I was tasked to give the lecture with a title that starts with the letter E, and this coincides with the second to the last letter in 97, the batch of the Silver Jubilarians of the UP College of Medicine this year. E for eczema and other dermatoses of the mother and child. This will, of course, be not a comprehensive lecture on the skin diseases seen in the mother and child. My discussion will focus on some dermatoses specific to the expectant mother and the mother immediately postpartum, as well as the newborn. Many of us Filipinos embrace to some extent certain things about pregnancy, and one of this is paglilihi. We believe that what a pregnant woman craves for while pregnant will affect how the child will look like. I remember that my mom used to tell me na pinaglihi niya ako sa mari at singkamas, kaya daw ako medyo maputi. I was also born with very little hair, so when my mom became pregnant with my younger siblings, she started eating balut. And she would say that this was the reason they were all born with hair. Another pregnancy myth that we consciously or unconsciously believe in reminded me of this jeepney sandwich. Ang maganda sa kanan, ang cute sa kaliwa, ang sexy sa harap, ang pangit, wala nang upuan, kaya kung pwede sumabit ka na lang. Because isn't it they say that if a pregnant woman is blooming o hiyang sa kanya ang pagbubuntis, then most probably the baby is a boy. Ay, sorry, girl pala. Kapag blooming ang buntis, babae ang anak. If the pregnant woman is not blooming, then her baby is a boy. So we can just imagine the pressure that women experience during their pregnancy. All eyes are on her. What more when she starts to develop changes in her skin? It is therefore important for us, healthcare workers, especially those with pregnant patients, to be aware of the normal and abnormal changes in the skin during pregnancy. I have nothing to disclose except for the fact that I am not a mother, but I am aware of the pressure and sacrifices that loving mothers experience, having witnessed them in my own mother, in my siblings, friends, colleagues, and patients who are mothers. My lecture will be divided into two. In the first part, we will tackle pregnancy dermatosis, and we will finish off with neonatal dermatosis. Now, going back to the title, eczema and other dermatoses in the mother and child, here's a word about eczema. The words dermatitis and eczema are used interchangeably, although when the term eczema is used on its own, it usually refers to atopic dermatitis. When we describe skin lesions as eczematous, we mean that the lesions are scaly, crusted, and at times with serous discharge. The term dermatitis is often used with qualifiers like contact dermatitis, seborrheic dermatitis, and diaper dermatitis. Now to the belly of the matter, pregnancy dermatosis. Let's start with the case of Betty Lafea. Betty, a 32-year-old female, primigravid, in her second trimester of pregnancy, came for an increase in what she called warts on her face, neck, chest, both axillae and inframammary areas. On physical exam, there are multiple discrete 2 to 4 millimeters flesh-colored papules on her face and multiple hyperpigmented and flesh-colored pedunculated papules on her neck. Now she wishes to have them removed. Although people call these lesions warts, they're actually skin tags. In the pregnant woman, they are called molluscum fibrosum gravidarum and appear on the face, neck, chest, axillae, and inframammary areas during the second half of pregnancy. For Betty, we assured her that these lesions are completely benign and non-infectious. We advised her to wait until after delivery for the skin tags to be removed. And we told her that some may even spontaneously regress postpartum. Aside from molluscum fibrosum gravidarum or skin tags, 90% of pregnant women experience some form of hyperpigmentation. Areas that are already dark may even get darker, including the areolae, pubis, neck, axillae, and inner thighs. Shown here is a hyperpigmented linear streak from the sternal xiphoid process crossing the umbilicus to the symphysis pubis, and this is called linea nigra or linea nigra. Another common pigmentary change in pregnancy is melasma, which used to be called cloasma and mask of pregnancy. It presents as a blotchy, hyperpigmented patch on the face during the second half of pregnancy. This occurs in 45 to 75% of pregnant women. Common patterns are centrofacial, malar, or mandibular. It regresses postpartum and less than 10% persist. The development of melasma may be due to a combination of factors such as sun exposure, cosmetics, genetics, increase in estrogen, progesterone, and melanocyte-stimulating hormone. Its treatment is challenging and success depends on the depth of the pigment. Most melasma from pregnancy are of the epidermal type, and for this, the triple combination of hydroquinone, tretinoin, and corticosteroid every night is helpful. Depigmentation is achieved in 6 weeks. Patients with melasma should also be advised to avoid sun exposure, to put on sunscreen, and avoid the use of irritating cosmetics. Striae present in the pregnant woman is called striae gravidarum. It presents late in the second trimester and involves the abdomen, breasts, axillae, lower back, buttocks, arms, and thighs. Now let's go to hair changes during pregnancy. Each strand of hair goes through 3 phases. Anagen, which is the growth phase, catagen, the transition phase, and telogen, the rest phase, before the strand sheds. Anagen lasts for 3 years, catagen for 3 weeks, and telogen for 3 months.